Assalamu alaikum and very good afternoon to all. Really honored to be here. I would like to express my humble gratitude and thanks to the whole executive committee of BSCI, especially Scientific Secretary Professor M.J. Ajam, Secretary General Professor Mir Jamaluddin and President Professor Fazlur Rahman and all the foreign delegates for coming here and arranging such a wonderful conference so that we can share our knowledge and experience and treat our patients better. My today's topic is IVUS guided left main bifurcation PCI. How I do it. Nothing to disclose. IVUS guidance to optimize bifurcation stenting. We do pre-PCI IVUS and post-PCI IVUS. Before doing the intervention, we see vessel size, plaque distribution, like in this case, which Fojila madam showed, did rota or not, and sideband disease for seeing whether we should go for 1 or 2 stent strategy. And post-PCI IVUS, we see stent apposition, expansion, any complication, and any side branch compromise. So while doing the left main PCI, we need to do IVUS both from SARC and LAD because we need to assess the both SARC and LAD ostium properly. Otherwise, with one vessel, we won't get the good information. And preference for provisional stenting, while left main to LAD stenting, one stent strategy, we need to see whether SARC is small, no SARC disease, lesion in the SARC ostium not extending above 5 mm, wide angle between SARC and LAD, and no significant SARC ostial disease. And same, sometimes we do left main to SARC stenting as well when LAD ostium is not affected and SARC is bigger vessel. But we do 2 stent techniques sometimes from the beginning when the SARC is not small and there is significant long lesion, ostial more than 5 mm, complex lesion, angle is narrow, and then we need to decide from the beginning 2 stent strategy. And sometime after 1 stent strategy, we need to convert it into 2 stent strategy by provisional stenting when after doing the main vessel stent, there is reduced flow, TME3 flow, dissection or FFR IFR is less than 0.8 or 0.9 in case of IFR. So while planning the strategy from left main to single stent strategy, we need to see the landing zone. The landing zone by IVUS, we have to see the plaque burden is less than 50% or 40%. And at the same time, we have to size the stent in the size of distal vessel and then dilate proximally with a higher balloon. And nowadays, all the stents can be get bigger size by 1 to 1.5 mm. And while doing 2 stent strategy, we need to see the SARC vessel as well while doing TK crush or any tap, any measure. And you can see that modern stents, we can take it up to 1.15 mm more than their size. So proximal stent can be dilated with a higher balloon. And here is an example in landing zone, SARC and LAD is 3 mm size, but left main was 4 to 4.5 mm. So putting a stent, we can take a higher balloon and make left main stent with a higher balloon pressure up to 4 to 4.5. And this is a very important slide. We all have seen it many times in the conference that after doing the stenting, post-stent IVUS estimation of the minimal stent luminal area. In our subcontinent, it should be 5, 6, 7, 8. 5 is SARC ostium, 6 is LAD ostium, confluence 7, and left main will be minimum 8 mm square. If we can achieve this figure, then long-term outcome is very good. Chance of restenosis is very low. And in Western population, it's a bit higher, 6, 7, 8, 10. Again, this is all the, then again post IVUS, we need to see the stent age, whether there is a dissection or not, stent expansion, which I've already shown, minimal stent luminal area, which should be at least 90% than the normal reference vessel diameter, and stent apposition as well. And in all the pooled analysis of the data, we can see IVUS guided left main PCI does better than angio guided left main PCI. So this is a case example. A 76-year-old fragile lady got admitted with chest pain in my hospital for 2 days. Tropoid leaked. Echo showed inferior wall hypokinesia. She had a history of LAD and SARC stenting. And ECG showed dynamic changes. So CAG planned for index procedure. You can see the huge chunk of calcium. The first welcome look was not pleasing. And you can see there is significant lesion in proximal LAD and also SARC ostium and SARC proximal lesion and also ISR. Here in this view, though LAD ostium does not look so much significantly stenosed, but in IVUS it showed there is a calcium almost 270 degree and also ostium is diameter was 4.6 or 4.5 like that. RCA was normal. So what's the plan now? Problem in hand, 74-year-old fragile lady, non-STMI, ongoing chest pain, DVT with proximal lesion in LAD and SARC ostial lesion and heavy calcification ISR. Well, PCI and cabbage as is a recent MI, old lady, so party opted for PCI. Challenges in PCI was ostial involvement of both LAD and SARC. SARC is quite evident, but LAD I am not sure. So decided to take help from imaging, heavy calcification. To see the amount of calcification we kept in our armamentarium cutting balloon IVL rota. Left main involvement, left main seems normal, but both the ostial may be involved. So what will be our strategy? Single, double strand, or which technique will take? So XB guide catheter, you can see clearly the SARC ostium and proximal ISR. LAD there is a proximal tight lesion, but ostium seems more or less a bit hazy. So BMW were taken to cross the SARC lesion, IVUS catheter taken, but you can see in the second picture, the IVUS catheter is backing out. It does not cross the lesion, the calcified part. So 2.5 in 15 balloon taken, tried to dilate the proximal SARC but failed. It didn't open up well. So heavy calcification, what now? Options, cutting balloon, OPM balloon, IVL, rota. But remember, this is a MI setting and ISR. So in MI setting, rota is a bit, it can create no flow, slow flow, and MI setting, the outcome is not always good. And there is also ISR. So considering all the factors, we opted to go for IVL, punch the lesion rather than drill. So we took a 2.5 into 12 shockwave balloon and inflated it at 4 atmosphere, started the pulse wave in bouts of 10 waves at a time. This is the IVL. And you can see the stent V's. So during the pulse generation, we can see the spikes in the ECG monitor. 10 pulses can be given at a time, total 40 shocks given. And post IVL, the ostium of the SARC was further dilated, first using 3 into 12 balloon. Next, IVUS was done in SARC and we could see the proximal part was still not optimally dilated. The right picture is still picture where proximal part showed still narrowed. So the lesion was further dilated with a 3.5 into 15 safeguard double wire balloon. There are 2 wires and then a short 3.5 into 8 balloon on the stenos part, most stenos part, to create extra pressure on a particular part. Remember, before putting a stent in the calcified lesion, first you must prepare the bed. If you put stent, you can post dilate it. So you can see the lesion was well opened. So again we did post dilation IVUS. So IVUS done 3 times in SARC and seemed well dilated. The calcium rims were cracked. To have an optimal stent expansion, you need to have 2 cracks in the calcium, especially in the opposite side. The arrow showed 2 cracks in the calcium. There is a gap. So after SARC bed preparation, we negotiated to the LAD lesion and opted for IVUS to see ostial LAD. IVUS was done in LAD which showed significant stenosis and calcium more than 270 degree in the proximal LAD. The right still picture can show the whole calcium excepting the upper 12 to 3 part, the whole lower part is calcified. So there we also took the IVL and then NC balloon, dilated the lesion, ISR as well. After predilation, IVUS was repeated again in the LED to see calcium was cracked or not. So you can see dissection flaps and reverberation shadow. When the calcium will be cracked, you can see the reverberation beside the calcium. Before calcium is well cracked, you can't see beyond the calcium. It is always hollow, black. So what now? So now we come to the decision of the technique we would prefer. Left main, no significant involvement, but we had both ostial involvement of the LED and SAG, left co-dominant. So we opted for decay crash. So this is a 3x28 synergy stent was taken in the SAG, went smoothly, and we put a balloon in the left main, 3.5 into 12 balloon. Then put the stent in the SAG in optimal pressure, keeping 1 to 2 start in the left main. And then crash the stent with 3.5 into 15 balloon in the right picture, second picture. So rewiring was done using a BMW wire through the proximal start of the stent. We can see by the cine picture. And next two 3.5 and 15 balloon were taken and placed properly and did the first kiss. And then 3.524 synergy stent was taken from left main to LED, and the wire on the SAG was taken out, inflating LED stent to do the second crash. The pot was done with 4.5 into 8 balloon because we measured the size of left main by IVUS, and then SAG was rewired again with BMW wire through proximal start. Again, 2 balloons were taken, 3.515, second kiss was done. Finally, again, repot was done with 4.5 into 8 balloon. And this is the post-stent IVUS of LED SAG. LED IVUS, you can see the MLA of proximal LED is now 8 millimeter square. And MLA of SAG ostium was 5 millimeter square. So 5 SAG, LED 7. And MLA of left main is 11. This is the last picture. So 5, 8, and 11. We need 5, 6, 7, 8. 5, 6, 8. Final angiogram. So take home message. IVUS guidance for left main PCI is helpful to 1. Planning the procedure, whether you do single or double stents by seeing the side branch ostium. Need for plaque modification like rota IVL, sizing the length and width of the stent. What is the length of the stent and width? Width should be taken by the distal size of the vessel, landing zone. Optimizing PCI result for long-term outcome like minimal stent luminal area 5, 6, 7, 8, and monitoring complication like edge dissections or stent expansion or stent apposition. IVUS guidance of left main stenting provides a prognostic benefit with respect to the use of angiography alone, particularly when using a protocol with predefined optimization criteria. Thank you.